Good afternoon, everybody. My name is Keela Herr, and I'm a professor at the University of Iowa and have spent my academic career engaged in a program of research focused on trying to improve the quality of pain assessment and management in older people. And today I'm here representing the Hospice and Palliative Nurses Association and also my own commitment to trying to improve pain in our older adult population. I think the panelists have done a very nice job in raising some of the issues that we face in trying to address the challenges of chronic pain management, which we acknowledge is certainly at a crisis in our country that causes severe disability and burden and suffering, and one that's only going to continue to grow. We've talked earlier today about the growth of the aging population, who is one of the segments of our population that bears the greater burden related to chronic pain problems and the effective management of those. The Hospice and Palliative Nurses Association would endorse that individuals that are suffering from chronic pain deserve palliative treatment and palliative care approaches to managing that pain. And throughout the conversations here, and we've touched at different points today about the complexity of chronic pain, and it isn't something that is a quick fix. It's a very complex problem with multiple dimensions, and there are multiple challenges and barriers that have to be addressed for us to be able to do so effectively. The panel brought up a number of these: regulatory, legislative barriers, stigma barriers, lack of knowledge and fear of providers in how to treat chronic pain effectively, lack of access, and lack of funding and payment, to name just a few of those. And there are many more, which I'm sure your meeting the last couple of days addressed, Myra, as well. I thought what I would do to start the conversation is to talk about three areas of solution with a few comments related to them. That will help us to move forward in addressing the problems of chronic pain from a palliative care perspective. We've heard throughout the day, and the panel mentioned today, the lack of healthcare providers. And this truly is a real crisis for our society, and particularly to be able to meet the needs of our older population that are going to need treatment. I've been working on a project with a national group that's been looking at ways to address the problem from an educational perspective. And I want to start first by mentioning what we have right now as far as the level of preparation of our pre-licensure healthcare professionals in this country. And it's very sad. There was another recent paper just came out by Beth Murenson that indicated that the median hours that medical students receive on pain in general, not just chronic pain, but pain in general, is 7 hours in their 4 years. Now, it takes that long just to learn the language and the words that we're supposed to be using, let alone all of the aspects of how you assess and the multiple treatment approaches that are necessary. So the Mayday Fund has invested some resources in bringing together an interprofessional group of experts to develop core pain competencies. You may have seen the publication in Pain Medicine of what this group of diverse professionals, including alternative therapists, social work, psychology, medicine, nursing, veterinary medicine. And the reason they were included was because Judy Watt-Watson, who's a nursing colleague from Canada, did a study in Canada on educational content and found that veterinary students receive 7 times the amount of content on pain management than do nurses or physicians. So they were included in the consensus to come together. But anyway, the group was able to come together and really identify these are the core elements of good pain care that every health professional needs. And I think we've endorsed that today. It isn't just medicine or nursing or other specialties that need to know how to provide pain care, but there are core things that everyone needs to be able to address appropriately based on the level of whatever it is that their discipline is contributing. So that paper is published, and we're moving forward now trying to disseminate and identify strategies to actually make change. This has been known for years that we don't have a lot of attention in our educational programs, but we're trying to move forward with that And one of the ways we're doing it is working through medical licensing boards and state boards of nursing. And unfortunately, it comes back to people respond to things that they're judged on, how they're being measured. And academicians, their outcome, or students, are judged based on how well do they perform on licensing examinations. So that's one way to try to get at it. And you hate to carry the stick instead of the carrot, but sometimes that's what it takes to get us to move forward. The other thing I want to mention is a movement or an initiative by NIH and the Pain Consortium, and funding that they have dedicated in the last couple of years to establish centers for pain excellence around the country that are developing educational resources that will be available to all health professional educators to help them to do a better job at integrating content on how you manage pain effectively. I do think that it's hard to teach our students how to do things well when the faculty don't know how to do it well and have the ability and the resources to do that. So this is one initiative by the government that I think is going to be helpful to us. It was mentioned by the panel also about the importance of interprofessional education, and if chronic pain has to be addressed from an interdisciplinary approach or an integrative approach, as Bob mentioned. But to do that, you can't just educate people in silos and then throw them together afterwards and expect them to be able to work well together and to know how to have good communication and decision-making processes. So interprofessional education early on, I think, is essential. And we do have pilot projects where this is happening, but it needs to be the norm. So all students experience this regardless of their background. I want to mention for a second element is access. I'm not going to talk a lot about that. It's been identified throughout the day that we have issues and concerns about payment for treatment, both pharmacologic and primarily non-pharmacologic interventions. Particularly in geriatric care, access to behavioral therapies and mental health therapies that are really crucial elements of a chronic pain management program are poor, and it's an area that needs to be addressed. But if we believe that educating students to start the whole process is really an essential element, then there has to be an ability for them to provide what we teach them is quality care. So it has to be addressed. And then the third element that I wanted to talk about is science and the research base for what we do. As clinicians, we practice best practices, and it's based on whatever the best evidence that's available to us from the scientific community. And that changes over time. And there certainly are many, many gaps of what are the best approaches, what are the best pharmacological approaches, what are the best non-drug approaches, how do we tailor those approaches to the unique populations, particularly those that are vulnerable, that are dealing with the complex chronic pain problems. So we do need much more research, and I know Pat Grady's going to be up next, and hopefully she will share more with us about how we're advancing in that area. But in moving from learning more about the mechanisms of pain and the treatment approaches of pain, I think another important area that we have to invest resources, and we are federally, is in the translation of what we learn into practice. You know, I think the recent information has said that we've moved from taking 17 years to get a new idea into practice to 15, so yay. But we can't wait. You know, as we uncover new information, new approaches to improve our treatment, we have to find ways to get it into practice more quickly so that there's consistent use and application of best practices. And to not beat ourselves over the heads when new information maybe changes the perspective on what we've done in the past. We operate from what we know and what science has told us is the best at the time, and then we have to continually change our best practices and educate and communicate and disseminate those. So those are my thoughts to kick off the discussion. Thank you.
One very quick statement and then a question for the panel. Dr. Twillman, I very much appreciated your comments and the concepts that you conveyed. I, as a palliative care physician, I do want to voice an exception to the terminology. I think the distinction that you were making from my perspective and from a palliative care perspective is the distinction between multidisciplinary and interdisciplinary. And that interdisciplinary model where the multiple professionals who have assessed and made recommendations for a patient are actually in the same room is what makes palliative care special. It adds a dimension that is person-centered and that is much more responsive to the real needs of the person and family than a multidisciplinary model, which you mentioned. So from my perspective, and if we're going to bring the two disciplines more in sync, I would promote the multidisciplinary distinction between multidisciplinary and interdisciplinary. My main comment, though, is that I know, and some of my colleagues who've gone out into practice who are interventional pain specialists have opened up centers in their various communities and are becoming millionaires many times over in interventional pain management. And my question is there some entity that is in some way distinguishing by a certification or some acknowledgement that to earn the acknowledgement of a certified pain center, the infrastructure must include an interdisciplinary team and a multimodal approach that clearly involves mental health and OT and PT and these other person-centered approaches to, in fact, help one live with the pain that we are unable to ultimately relieve, but that is part of this person's life. And otherwise, if not, how can the unsuspecting person with pain or a family member of someone living with pain know where to take their loved one?
I'll try to answer that. I think that you bring up excellent points, and these are serious problems with our healthcare system that you've identified. It is true. There are pain physicians who are truly only interventional. They're really not pain physicians. They're just injectionists. And then there are others, and there is no certifying body to really identify individuals who have all of these skills together. There are efforts now by many of us in some of the professional organizations to go there, but there are a lot of barriers for that, a lot of politics because it's money. That prevents a lot of consensus around this. CMS is a problem because that requires residency programs, or presumably it might require a residency program for which there'd have to be new funding. So you'd steal from anesthesia or neurology or internal medicine or neurosurgery some of the funds right now rather than create new opportunities for a new specialty. But most of us out there that are working in the field believe in what you said. We believe we need to have an interdisciplinary approach to the treatment of pain, and we need people trained that way. And we need a lot of training to get there. But we don't have the buy-in at the medical schools. That's what Keila had indicated. And we just don't have enough people out there interested. And we have gone down this path for so long. It's so fragmented and so much money exists in these different silos. This is a really big challenge for us to overcome, but a point well taken.
Thank you, Lynn. Bob, I'm wondering if you wanted to comment as well.
One of the other routes to get to that point that we might consider is third-party payers other than Medicare or Medicaid, because perhaps we can convince some of the private insurance companies that really is the right model with the best outcomes and the most cost-effective treatment, but we aren't there yet. We think we have the evidence for it, but convincing them to actually do it's a whole other issue. And we can have a discussion about the terminology, because I have a different meaning for multidisciplinary that's even less appealing.
Some of you know my sweet dear husband, Truman, and a few years ago, he was just having excruciating pain from spinal stenosis. And in the IOM report, we pointed out that the average chronic pain patient sees 7 physicians over a 4-year period before he or she gets any relief. And then we label them doctor shoppers very often. But when we went to yet another pain clinic that our primary care physician had referred us to, when the advanced practice nurse came in to do the intake, and I said, I want to know about the philosophy that underpins this clinic. Do you provide integrative biopsychosocial care? My husband was a former football player in the Southwest Conference, and he was really struggling with what this meant to him at many levels. And instantly she said, I think you'll need to see the physician, and left the room. So, it's really critical, I think, that patients and their families understand what good chronic pain care looks like. But Ira, this is exactly the same issue that we addressed early in the palliative care movement. Do you push for consumer demand before you have capacity? And it's sort of a chicken and an egg issue. So we absolutely have to, I think, be working on multiple fronts around this issue. David, you had a question? Oh, I'm sorry,
Yeah.
Richard.
Well,
Richard,
you know,
then
the
David.
founding father of this field, John Bonica, built the model exactly on the way you said, interdisciplinary, rehabilitation focused, in fact, right? And there was, and I must admit ignorance here, because I don't know what's happened to it, but there was a accrediting agency, CARF, which did accredit interdisciplinary rehabilitation-focused pain clinics. I think the CARF accreditation went away because all of the programs went away. I know in my lifetime of practicing in New York City in a cancer hospital, we used to have some capacity to refer people with chronic pain of non-cancer causes to rehabilitation-focused clinics in New York City, both of which disappeared in my lifetime as a practitioner there. They were deemed not cost-effective, even though there's actually a small but nonetheless existent evidentiary base that you in fact improve outcomes. So I think this is one huge policy issue, is how do we resurrect actually the multidisciplinary rehabilitation-focused pain program and accredit it, and for all the reasons that you mentioned.
When we published the IOM report, we were only able to find 122 interdisciplinary pain programs, chronic pain programs around the country, although there was reason to believe that a decade before there had been more than 1,000. We could not, in fact, verify that number. But with the passage of the Patient Protection Affordable Care Act and the emergence of accountable care organizations, we now see the reconstruction of some of those clinics that were dismantled. So I think that this is, we had someone quote the other day about the best of times and worst of times. I think there are real opportunities to try to get this right in the context of reform associated with patient protection, affordable care. David.
Well, I have two things to mention. One would be a comment, and the other is a compliment, if I may. But the comment relates to both when we talked about palliative care this morning at times, and now this afternoon in particular, I heard several mentions here about lack of education in the medical schools and what have you. I'm not associated with the AAMC anymore. For those of you not from the Association of Medical Schools in this country, American Association of Medical Colleges. But I do have a suggestion based on my experience there. There's a major movement right now in medical education and, in fact, across clinical education around competency-based education, not simply completing a rotation on a particular service or what have you, or so many hours of biochemistry or pharmacology or whatever else it might be. So I think you're at a particularly advantageous time to begin to talk with the people who are building these competency-based models and working on them for both palliative care and pain medicine. I know, for example, in the pain medicine area, Scott Fishman has met with the AAMC because I set up the meetings. I arranged the meetings for him to begin those conversations, for example. And it's a great thing for you to think about. I think, unfortunately, that still is not going to be it's not going to fix the problem for the next 15 years. I mean, we have to go well beyond that and deal with, with clinicians and continuing professional education for sure. But I think the two areas can be, both of you can benefit from thinking about those as ways of enhancing this movement downstream. Second thing I wanted to mention, and it just really struck me when we were doing this, when this topic was introduced, Myra, because I know in my own circumstance, we were so tightly linked between our pain medicine practice and our palliative care practices at Penn, that seeing you bring these two groups together at the same time, I think is an extremely valuable thing to do. And I personally want to thank you for doing that. And similarly, I think, as most of you know, the work that I'm doing now with CTAC was fostered by the work, by your leadership and that of the Center of Practical Bioethics, and seeing those things happen. So it's another example of you and your organization being a real catalyst for addressing some common issues that we all face that are not very well handled in this country in healthcare. So thank you.
Thank you, David. That's very generous. Kathy?
See, Aviva can steal the microphone for me. I have more of a practice question than a policy question. Actually, since we have so many fabulous doctors in the room, will you talk about the correlation or relationship between pain and the whole range of dementia, delirium, cognitive impairment, and how that makes it more complicated to support someone and their family, both kind of from the medical side, but also from the community side? I think of the growing numbers of people with cognitive impairment who kind of cross all of these fields.
She's the world expert.
Yeah. Yeah, right. Yeah, thanks for the question. So you're raising a really important point when you're talking about aging and issues related to pain management. We know that 50 to 80% of older people in nursing homes experience pain problems that impact their function in daily life, and half of those have dementia. And the biggest challenge related to pain and dementia and delirium or other related cognitive impairments is differentiating when they're experiencing pain and what behaviors are related to other like problems. We know that disturbing and distressing behaviors that people with dementia often exhibit that are maybe from some unmet need could be related to pain. And so some of those behaviors are triggers and things that we look for in evaluating people in nursing homes that have dementia, has potential indicators of pain. And it doesn't tell us for sure that pain is the problem, but it lets us know that it needs to be in the things that we're trying to differentiate as far as the cause. The problem is there are many myths and misbeliefs about pain in dementia in particular, that it isn't the same or that people that can no longer express pain are not experiencing it, but the studies have shown that yes, they are. They're just not being identified and they're not being treated. And so there are there's huge undertreatment of pain in that population, and it certainly is a priority area for further study and better treatment. And I know you have other things you want to talk about, but I'd be happy to talk a little bit later with you about more.
Well, I actually want to ask the audience a question because I just asked Jim if someone on the panel knows this answer. I would be grateful. But at the meeting of the American Academy of Hospice and Palliative Medicine in 2012, in the State of the Science section, there was a report, Kathy, on a research study that looked at the use of low-dose opioids among nursing home residents who were demented and who, frankly, were acting out. And their data were that it was a very effective treatment, not only for pain, but for the person, for sort of calmness and function and so forth. Does anybody remember the study I'm talking about, or the report? Christian?
Yeah, I
Tylenol
was
as
going to
well.
talk about the
Okay,
Tylenol study.
great.
Yeah.
Okay, great.
Yeah, so the Tylenol study was they'd identified, it's just a case series. There were 8 patients who were identified as having difficult behavior, and they decided to give them Tylenol, and 7 of the 8 had a decrease in the number of incidents of difficult behavior, and 6 of the 8 came off their psychotropic medications.
There's also a more current study that was done in Denmark that was a randomized control trial looking at an algorithm for treating pain in people with dementia who had disturbing, distressing behaviors. And the protocol started with acetaminophen, advanced to low-dose opioid, buprenorphine, and then gabapentin. And what they found were significant improvement in the behaviors and in what was assumed to be pain then because of the treatment. But the majority of them responded with just around-the-clock acetaminophen. So it seems to support that there's a lot of underlying pain problems that are not being recognized and that we may be able to manage with one of our safest treatment options.
Thanks. Somebody said to me after the little talk about my husband Brooks' experience, well, it's really wonderful to hear some positive things, that things can go well. So this is a little story about methadone. So Brooke was keeping up that average number of visits to various pain management things. He had acupuncture and he had, you name it, all of that stuff. Finally, when one inpatient admission, the palliative care team came around and said, well, why don't we try low-dose methadone? Terrific. But here was the good part. Right? It worked. You saw that we had 12 caregivers. There were 12, all those people lined up in the backyard there. The respiratory therapist, the CNA, the pre-med students, and the former drywaller. They made every single one of them come into the hospital and receive a 1-hour training session. Every single one of them had to do that before they would let him go home with this. And we never, ever had any medication errors with methadone.
Was that on
Except, what?
I want to know if that's on Earth.
Right. Except that he did have a serious overdose in the step-down unit from the ICU. That was inadequately trained house staff.
Yeah. I think that's a beautiful story.
Isn't that
Sad,
amazing?
but okay.
Yeah. No, he survived. Oh, well, what they intimated was that the diaphragm pacer was what kept him going.
Wow.
How's
Well,
that for a piece of luck?
I
Right.
thank you for sharing that, because this is the story with methadone. If you don't know how to prescribe it, it's night and day from those who do. It's a very effective analgesic, particularly low dose, and we need to have it available, but no one should prescribe it if they don't know how.
But they don't know that they don't know how. That's the problem.
Assume
Right.
everyone.
Right. It was a nurse who said, you know, after this, there had been a rash of fatalities apparently in that unit. The nurse said, we've been doing a lot of that recently. I believe they've corrected that problem, but
Hopefully.
I hope.
So if you actually look at the use of methadone in the VA system or opioids in the VA system, if someone's been on morphine and you want to switch them out because of side effects, delirium, other things, the computer recommends methadone as the medication. Yet most of our physicians have no training in how to use methadone. And I even come back to the opioid-associated deaths. It's not, there are some in teenagers. There are many rural males in their late 30s, early 40s who are actually dying of opioid-associated deaths in this epidemic. And I worry that is that part of the whole system, uneducated physicians using this drug.
Yeah, I just wanted to make a comment about unintended consequences, since we're talking about pain management, and hospice uses pain management as one of its primary interventions. And Methadone certainly is one of them in the opioids. And trying to get 24/7 access in the communities and patients' homes is really, really hard. And it's hard to find a physician willing to go through the rigmarole to make it happen. And so that's one of the things we spend a lot of time trying to accomplish for patients trying to stay home.
Okay, we will wrap up and get back on schedule here. I wanted to conclude by simply saying that we've talked about clinical reasons, we've talked about humanistic reasons, we've talked about all kinds of reasons why this is important to each one of us. Yesterday, Dr. Phil Pizzo, who was the immediate past dean of the medical school at Stanford, and who was one of the co-chairs of the IOM Pain Committee, and is now one of the co-chairs of the IOM End of Life Committee, came and shared his personal story. And he's a pediatric oncologist. His wife has lived with chronic pain. He was a fabulous chair of the committee that Richard and I served on around pain. But not long after that committee completed its work, Phil been over in his office and began to experience excruciating pain and had to call for help. And over a period, I think, of almost 18 months, he went from being a man who runs at least 3 marathons a year and participates in extreme sports events to being a person who couldn't get out of bed and said from right here that he could not have walked to the wall back there and back. And that in the course of this, he didn't want to take opioids unless he really needed them. But he was actually told that, transition from being the dean to being retirement is really a big deal. And could this just possibly be all in your head? Maybe you're just a little depressed. And experienced 4 MRIs, seeing multiple physicians, when they finally were able to, and almost accidentally, diagnose a very rare neurological problem. And he was one of the people living with chronic pain who was blessed to have his problem remedied by a surgical procedure. But and I'm sure he didn't receive care at Stanford. I just don't know where this could have been. But after the surgery, because he had it was assumed because of his terrible condition that he had been on high doses of opioids, although he had not. He was overdosed and went into cardiac arrest and nearly died. And it meant weeks and months more in the intensive care unit. And then when he finally, again, transitioned to a rehabilitation facility, he was again overdosed and did not nearly die this time, but it meant much, much more treatment and care. And Phil made a comment yesterday that for those of you who know him, he is a very humble, unassuming, brilliant man. But that he never tried to play the I'm the dean card ever while he has been at Stanford. And that he really did think, being the chair of the committee, that he understood this. But in the course of this, he began to think, if this is my experience, because these people do know I was the dean of the School of Medicine at Stanford, what is it like for other people? And he also made a comment that he said, even though he thought he understood, he did not know. He published a piece in the New England Journal of Medicine in the Perspectives section about this. And I encourage you to go back and read Dr. Pizzo's personal telling of the story. Because honest to Pete, we have got to do better than this. We absolutely have to do better than this. It's the #1 reason people seek medical care. Of the top 10 reasons that people go into ERs, 5 of them are pain-related. So we are very grateful, Kathy, that you were open to us kind of deviating from the usual palliative care, and David letting us conjoin these 2 very important public health issues. And I also want to acknowledge that we all know that addiction is a major public health issue in this society as well. We have got to be better at providing care, giving access to care for people who do struggle with addictions. We cannot be competitive among public health causes. We have to be working collaborative if, in fact, we're focused on wellness, well-being, and health. Thank you all.
Myra, can I just, one comment there. In the last 2 days, 3 days, the stigmatizing nature of pain has actually been raised. And I would actually also say the WHO has stopped using the language addiction because addiction is a stigmatizing word as well. It's dependency syndrome, but the whole people with pain feel stigmatized, chronic pain, and it's actually true of addiction. Dependency syndrome is the new language, the new word. It's going to be tough to overcome. But in actual fact, I think both of those conditions are very stigmatizing.
We actually had one participant in our meeting suggest that we make up a new name for chronic pain because there's so much stigma associated. People are weak, they are malingerers, it's all in their head, they just need to suck it up. So I think language is important, but we've also heard over the years people talking about changing the name of hospice. And I think the American public is pretty smart, and they figure this stuff out kind of no matter how we use the language, but I do think language matters. Jim, thank you. And thank you all, panel.